and hello, everyone. I am honored to be part of this symposium today. So thank you for asking me to speak. And what I will do over the next 30 minutes, maybe 35 minutes, I will speak about sleep. And some of these topics will, some of this talk will cover clinical issues as they pertain to our patients with Parkinson's disease. And I will also mention some of new research programs that we and others have been working on, trying to devise some new approaches how to manage issues that affect both sleep and alertness during the daytime among our patients with Parkinson's disease. So let me share my screen and let's see. I hope that you see my slides now. Do you see the slides? Somebody can let me know.
Yes, we can see the slides.
I always want to make sure. Perfect. Excellent. So let's start with some operational definitions right here and some terminology. Sleep is a very interesting physiological function, right? And we don't think much about it. Yeah, we take it for granted and we don't think much about it, right? We go to sleep, we wake up, we feel good or feel less good about the quality of our sleep. But we spend about, we spend about a third of our lives, maybe a little bit less, sleeping. So it's just a very important component of our being on this planet and interacting with each other. And here I'm showing you this graph to show you what we call sleep architecture, right? Every night of sleep has its own architecture. It has these major two sleep stages, which we call non-REM sleep and REM sleep. These stages of sleep, and then non-REM sleep has certain sub-stages as well. And as we go throughout the night, these stages of non-REM and REM sleep alternate, right? And create this nice graph here that I've shown you with all of these colors. I'm not going to go into details, but just wanted to show this graph maybe to illustrate that sleep is a really complex function, which, as I said before, we take it pretty much as granted. Another important concept that we need to recognize is that sleep changes as we age, right? And as we age, this architecture that I mentioned becomes different, becomes altered. And here, in this graph on the right, you see this architecture of a younger person on the top, of someone who is a little bit older, right? And you see these bars and this architecture that really doesn't look the same. It changes. And here I've illustrated what changes with our sleep as we age. And we know that the major risk factor for developing Parkinson's disease is age itself. So sometimes it's really hard to disentangle how much of a sleep problems that one face is related to Parkinson's disease and what may be the change that we all will face as we grow older. And you see that the napping becomes more common, that arousals are more frequent as well during the nighttime, sleep becomes less efficient, etc. And then on this slide, I show you this rather complex landscape of what are all factors, major factors actually, that can affect sleep. And in the center of this graph, you see something that says circadian system and homeostatic drive. We'll talk about that. These are two main processes that drive very well preserved balance between sleep and alertness. And then if someone has Parkinson's disease itself and all of those changes within the neurons and brain chemicals, etc., affect this nice balance itself, right? Parkinson's itself will affect sleep and wake regulation. And then outside of this major quadrant that is in the center, you have all of these other factors. some of which are associated with Parkinson's disease, like medications that patients receive, or motor symptoms of Parkinson's disease, such as tremors and dyskinesias. Some others not so much associated, like other sleep disorders that can coexist without relevance to Parkinson's disease whatsoever. So you really have a very complex picture of what can go wrong with sleep in individuals with Parkinson's disease, and as a matter of fact, with any other neurological disease, with any other neurodegenerative disease. This landscape looks very similar. But it just tells you that one needs to take a really broad view about what may be going on in order to devise the right approach, how to improve sleep. Roughly, we can, and this is at least how I think about sleep and alertness issues, I'd like to discuss problems that may affect daytime alertness, because a lot of patients with Parkinson's will have excessive sleepiness, but also what can go wrong at nighttime. And it is really safe to conclude that almost everyone will have one or another type of a problem with sleep or alertness throughout the lifetime of their Parkinson's disease. And what can go wrong at night? These are some of the major issues that can go wrong with the nighttime sleep. And we'll start with the most common, and this is sleep fragmentation. I'm sure that many of you can alert and are aware of this and can actually endorse that you really don't have a lot of problems falling asleep, but once you are asleep, that sleep becomes very fragmented. We call that sleep fragmentation. One can call it certain type of insomnia, like sleep maintenance insomnia, that would be fair to say. And this is by far the most common problem, and I think the most bothersome problem of sleep in the Parkinson's disease population. And I think if we can solve this issue of sleep fragmentation, the problems with sleep would not be so much bothersome to our patients, and also to their bed partners, their spouses, loved ones, who frequently have disturbed sleep as well. And the causes can be really very, very numerous. And I have listed here some of the causes. Certainly, emergence of Parkinson's symptoms during the nighttime can provoke these issues with sleep fragmentation. Patients frequently may have a mood symptoms such as anxiety or depressed mood, or some psychiatric symptoms with hallucinations, etc., that also affect sleep. Patients with Parkinson's frequently have autonomic dysfunction, and therefore they need to get up at night to urinate frequently, and that causes sleep problems. Sometimes it's difficult to go back to sleep. And certainly one thing that we should not overlook is that other sleep disorders may coexist with Parkinson's disease, and examples would be, for example, sleep apnea, that may have nothing to do with the Parkinson's disease process itself. It's just a sleep disorder that a lot of healthy individuals in the general populations also may have. So causes are really multifactorial, and therefore both us who are on a medical side, as well as patients and their caregivers and partners, should discuss during our appointments, because only through diving deep into these possibilities one may conclude what to do. And there is really a lot that can be done to manage sleep fragmentation. And I would probably start with the sleep hygiene, which is really not listed here. Those are principles that one should employ on a regular basis to assure that all predisposition for a good night of sleep are there. And I will not speak at length about this. And if you just simply Google sleep hygiene, you will find really great descriptions of what that may be. And that's relevant to all of us, not only to patients with Parkinson's disease. When it comes to specific Parkinson's recommendations, one may consider these options that are listed here. Obviously, if there is emergence of motor symptoms, or if the disease is at that stage where motor symptoms really present a huge issue for mobility overnight, and it is hard to turn in bed, etc., one may need to consider use of dopaminergic therapies either at bedtime, occasionally in the middle of the night as well. Some medicines that we use to treat patients with Parkinson's disease have alerting properties. Selagiline and amantadine are examples of this, and therefore I try to avoid using these medicines starting in the late afternoon and certainly not late in the evening before bedtime. Some common sense approaches are to really take diuretics or water pills earlier in the day to try to minimize the intake of fluid just before bedtime. These are some common approaches that are very relevant. One that is listed here is the use of bedside commode, and one may ask, well, how is that helping sleep? Well, it is really not helping sleep directly, but it's really maximizing your safety, especially if you are one of those patients that needs to get up at night and go to the bathroom a few times. And bathrooms are a scary place for patients with Parkinson's disease in the middle of the night. A lot of hard surfaces, potential for falls, potential for significant injuries. And therefore, I know a lot of patients may resist to it. It's not so elegant to have that bed commode. I really, however, strongly encourage it. If there is a need for frequent trips to the bathroom at night, I think that this is actually an excellent safety choice. I can't stress how this is important, at least the way I practice Parkinson's care. And then obviously, if patients have mood disorders and some psychiatric illnesses, as well as other primary sleep disorders, this is really in the domain of pharmacological or non-pharmacological management and therapies of these specific disorders that can affect sleep negatively and may really not be recognized at all. Now I'm going to move to another sleep disorder, which is very common, and it is called REM sleep behavior disorder. And this is where this terminology that I described at the beginning comes in handy. You see that there is a REM sleep in the title of this disorder, which means that this disorder happens only when patients are in a REM sleep. And in this disorder, when patients are in a REM sleep, they actually act out their dreams. And these are fancy diagnostic criteria, but I will tell you in a simple language what this disorder is about. When we all go to sleep and when we enter this stage of REM sleep, our muscles actually get paralyzed. We cannot move except the breathing muscles that keep us alive. And in that REM sleep also, dreams are happening, right? We dream when we enter REM sleep. And in this condition, these dreams are very active. And over 90% of cases, very negative dreams, aggressive dreams, where one needs to defend himself or find himself or herself in a very active situation, like playing sports or maybe escaping a fire. And because their bodies are not paralyzed during this REM sleep, these patients can act on these bad dreams and they can act them out. They react. So if they are fighting with someone, they can start punching and kicking and flailing. They can fall out of bed, and you can see why this disorder it's associated with dream enactment, that's the main feature of the disease, and how this can cause significant injuries. And here I wanted to show you illustration of 30 seconds of sleep, and you can see here at the top some brain waves, at the bottom how this individual breathes throughout the night. But in the middle, you see a lot of these vertical black lines here, which illustrates that the muscles of these individuals are active as he, in this case, is going through this stage of sleep, REM sleep. And this really tells us that these individuals really can act out these dreams, that he is not paralyzed during REM sleep, So this is a confirmation that we get on a sleep study that provides support for diagnosing someone with REM sleep behavior disorder. Why is this disease important, right? Well, this disease has been described a bit over 30 years ago now, and it used to be only a sleep disease, all right? Patients were treated for their sleep problems, but then it was discovered that majority of these patients who have this sleep disease, this acting out dreams, go on to develop Parkinson's disease or a cousin disorder called dementia with Lewy bodies. I'm sure you heard about that disease as well. And there is a third one, multiple systems atrophy. And these three diseases really are preceded very frequently by REM sleep behavior disorder. And it's actually considered that the REM sleep behavior disorder now represents one of the earliest stages that we can identify of evolving Parkinson's disease or one of these other disorders. And these are studies that have looked at the risk of development of Parkinson's or dementia if one has a REM sleep behavior disorder. And we believe that that number is now over 80% based on the studies that we have done so far. And this graph illustrates this here. Right here on the right side, we have a clinical Parkinson's disease. That's the point when one goes to see a physician and there are motor signs of Parkinson's disease that are needed on the examination for us to diagnose Parkinson's disease. But look what's happening many, many years, decades before that cutoff for the diagnosis of Parkinson's disease occurs. All of these other changes are gradually happening way before the onset of tremor or slowness or stiffness, etc. And this area here, so-called prodromal Parkinson's disease, is area of a big investigation because we believe that one should try to intervene in these early stages of neurodegeneration in order to maximize our chances to slow the progression of this neurodegenerative process and delay the onset of the disease. And this is one of the studies many of you probably heard, some of you may even be involved with it. It's a Parkinson's Progression Markers Initiative, or PPMI. It's sponsored by the Michael J. Fox Foundation for Parkinson's Research. And this study, in the first 10 years of its existence, has been focused on patients with very early Parkinson's disease, untreated patients with Parkinson's disease who were recruited to this study and then followed longitudinally to understand better what are the markers of progression of this disease. Over the past 2 years, as the study entered its second decade, the study started to enroll patients who are at risk to develop Parkinson's disease, patients who belong to the left of that time point when the diagnosis was made on that chart that I showed you on the slide before. Just wanted to make sure that you know that this study now recruits patients who have prodromal who are in prodromal stages of Parkinson's disease, who are at risk for Parkinson's disease, such as patients who have a loss of smell, which is one substantially significant marker of neurodegeneration, as well as patients who carry various genetic mutations related to Parkinson's disease, as well as patients with REM sleep behavior disorder. So what can be done for REM behavior disorder? Well, first of all, it needs to be recognized. We know that a large number of patients in general population has REM behavior disorder. Those of you who have it, you really need to understand this disease and also start with implementing safety measures in your sleeping environment, removing sharp objects from your nightstands, padding corners of that nightstand with a really soft material so that you don't hit the forehead if you act out your dreams against the hard surface. Trying to sleep on not a very tall bed and padding the floor maybe with a soft carpeting if fall would happen. that you minimize the risk for heart injuries, etc. When it comes to medications that can be used, we frequently use benzodiazepines, and clonazepam is one of the drugs that is frequently used for this, or melatonin, which is over-the-counter and very effective supplement in managing REM behavior disorder. Important point to know is that almost all antidepressants may exacerbate and worsen REM sleep behavior disorder. This is not to say that these medications should be stopped, but this is something that needs to be discussed with your healthcare provider to try to mitigate the risks and maybe try to avoid antidepressants or certain type of antidepressants that have a higher associations with emergence of REM sleep behavior disorder. And we can skip this table, and I already discussed treatment. And now the next disease, which I'm sure you've all heard about, is a restless leg syndrome. This is a primary sleep disorder in which patients complain about unpleasant sensation, usually that affect their legs, but it can affect other body parts. That usually starts in the late afternoon, early evening hours, for the quiet period of the day. Where these patients really, as they watch TV or remain quiet, reading a book, have uncomfortable sensation in their legs, which is so bad that it urges them to move, and they need to get up and walk around, and then that sensation subsides. But subsequently, as soon as they resume the sedentary position, this uncomfortable sensation reemerges again. And a lot of patients with Parkinson's disease will come and complain about, I have restless leg syndrome, and I want to tell you that a lot of you will not have it. Parkinson's disease symptoms can mimic symptoms of restless leg syndrome very well, and patients can frequently confuse their stiffness or uncomfortable restlessness that they have primarily from Parkinson's disease as symptoms of restless leg syndrome. And that's why we do not automatically assume that indeed one has restless leg syndrome and Parkinson's disease together until we probe further into this history that they are providing and draw the final conclusions. Here are some of the common medications that patients are being treated with. And the good news is that the same medications we use for the management of Parkinson's disease are also used in managing restless leg syndrome, but at much smaller doses. The problem with these drugs that over the course of years, patients who are being treated with, for example, dopamine agonists may experience that restless leg syndrome start to move earlier in the day and can even start in the early morning hours, which is a phenomenon called augmentation, very challenging to treat. And that's why we have these other choices that we frequently use in managing restless leg syndrome in patients with Parkinson's disease. But please do not assume that you have a restless leg syndrome automatically, because your symptoms of PD can mimic RLS very well. And that's why I advise you that you discuss this with your physician if this is the case. A little bit about sleep disorder breathing, sleep apnea. I think that here it's safe to say that sleep apnea is not any more common in Parkinson's patients compared to general population. We thought that's not the case in the past, but we know this is the case now. And the most of what's happening here in this condition, especially these most common forms, which is obstructive sleep apnea, is that as we fall, especially if we sleep on the back, that all of these soft throat tissue, including tongue, can close the airway, and therefore the air cannot go in and out of lungs. That causes us to wake up, ultimately gasping for air, and this is really what the sleep apnea is. And these are some of the treatment choices that one has for managing sleep apnea, but for the by far the most effective treatment modality is using CPAP, continuous positive airway pressure, where there is this machine that pushes just the regular air under pressure to keep that, to prevent that collapse of throat tissue during sleep and to keep the airways open. Now I want to move a little bit and talk about excessive daytime sleepiness. I know this is a fast pace, but a lot to cover. Sleepiness is a very common problem in patients with Parkinson's disease, much more common than in general population and in patients with some other chronic conditions. Not only that it negatively affects quality of life, but it affects safety of our patients. Because one can experience some phenomenon such as sleep attack or sudden onset sleep, for example, at the wheel. And here you have this large study conducted in Germany where 8% of patients with a driving license who have Parkinson's disease have experienced sudden onset sleep at the wheel. And a quarter of these patients had sleep attacks, so he had absolutely no warning sign that sleep can be heading their way as they are driving. Similarly, like for insomnia or sleep fragmentation problems or causes that lead to excessive daytime sleepiness are also very numerous, and you can see this is a common theme that for almost any sleep problem, there may be many causes that can be contributing to this and that we need to get to the bottom of it so that we can manage this condition well. How is this sleepiness addressed? I would say that the second bullet point here is the most critical point, that you need to get the feedback from your spouse, from your caregiver. How is your alertness during the daytime? Because many of our patients may not appreciate that they are napping and that they are quite sleepy during the daytime, they are falling asleep during meals, etc. And the next one, and two probably bullet points very important here, is that one needs to review medications because some of the medicines can cause problems with daytime alertness. And certainly one needs to eliminate the existence of other sleep problems, for example, like sleep apnea, which can make patients quite sleepy. These are treatment approaches that one can take to manage excessive daytime sleepiness. Unfortunately, medications that are being used are not so very effective in managing this excessive daytime sleepiness. So that's why we need to maximize the lifestyle modifications, if we can make them, to improve our alertness during the daytime if we have Parkinson's disease. For the end of the talk, I'm going to move to some other relatively newer areas, both of research and clinical care, that may be relevant for sleep and alertness in Parkinson's disease. And here I'm introducing you to this concept, circadian system. This is our timing system. We all have this central clock in our brain, which is called suprachiasmatic nucleus. It's a fancy term. It's a group of nerve cells that create our central clock. And then this central clock sends the information to all other areas of the brain. And each cell has its own clock in it. And to the periphery as well, as every of our organs and every organ system has its own internal clock. And it is this master clock then organizes our behavior and our function so that we can accommodate to these dark and light cycles that are imposed to us by rotation of Earth. And how can then the clock that sits deep in our brain sense this rotation of Earth and sense when it's dark time and time to sleep and when it's wake time, when do we need to get up? These are elements, so-called zeitgebers and time givers, that give cues to our clock so that clock inform our behaviors and physiology. And you see here, there is light, bright light, sunlight, which is the most important cueing factor for our clock. Light hits eye, eye is then connected directly to this internal clock, and that's how our timer can be appropriately synchronized to rotation of our planet. Similarly, feeding schedules and activity timing also can substantially help our clock to work properly, to tick properly, and therefore assume that we can function well. And this is another representation of what I just told you, right? There is SEM, that's our main clock, and that clock communicates with the rest of our body in various means, and that results at the end that our behavior and our functions are working properly. And in order for clock to do this right, light exposure and other non-photic Zeitgebers like meal timing, physical activity are really critical to assure the health of this clock. So now you can see, and I want to focus on this slide, you can see how light is really very important for us as a human beings, and it is also turned out to be very important for the story of Parkinson's disease. And this is just some, these are just some illustrations of the studies that have over the years tried to demonstrate the benefit of substantial light exposure at the right time to individuals with Parkinson's disease. And a few years ago now, we have conducted this trial in which we have used the light therapy, which was implemented with this light box, which is a portable light box. And we gave to our patients a light therapy twice a day. They were exposed to light in 1 hour intervals for 2 weeks. And after that, we also had a control condition. And after comparing effects of light, bright light with the control condition, we have derived conclusions that this exposure of this light benefited substantially sleep and alertness of our patients with Parkinson's disease. And for this study, we enrolled patients who had a lot of problems with excessive daytime sleepiness. No need to look into details of this table. The key home take message is that 2-week exposure to light substantially improved daytime alertness and nighttime sleep in patients with Parkinson's disease. And this trial has actually provided the basis for us to conduct a larger study, which has just finished enrollment. And this is a study that has been done across 25 sites in the United States. And the goal of this study was to assess whether giving light therapy once a day is as good as if we give it twice a day. So we have decided in this study to focus on how frequently we need to give light therapy and whether once versus twice a day is equally effective. And we wanted to confirm the effectiveness of light therapy country-wise, but this time in individuals who have poor nighttime sleepiness. In first study, we focused on excessive daytime sleepiness. Here, the main focus was on individuals who have poor sleep at night, but also on individuals who suffer from fatigue. And we will have a lot of other outcomes from this trial, which we expect to be reported in early spring next year. I have also told you that, I told you the story about the light, why light may be important, and not only for sleep, but maybe for some other mood problems and for fatigue and anxiety, etc. Another cue to our internal clock is physical activity and physical exercise. And I mentioned this to you, that's that non-photic cue for our internal clock. And this is a study that was done by Dr. Amara, and she introduced the exercise regimen. And then she looked what are the effects of exercise regimen on sleep in patients with Parkinson's disease. And this team has found that exercise routine has positive effect in improving sleep efficiency and also improving and increasing slow wave sleep, which is very important for memory consolidation. So this is another non-pharmacological intervention that we now know has positive effects on sleep and may increase those stages of sleep that are relevant for long-term cognitive health and which suffers very frequently in Parkinson's disease. So here, with these two aspects, I just wanted to illustrate how important are these common principles, right? Eat well, sleep well, do exercises. These are all things that we are talking about all the time. Many of us, including myself, are not taking full benefits of it. And this is something that only we can do, but something that doesn't cost us much and that doesn't cause side effects if done right. So what I would like to conclude this talk with is the fact that sleep hygiene is very important for us. I think that you need to discuss your sleep issues with your healthcare provider and that you need to pay attention to it. I know Parkinson's is a really complex disease, have a lot of other issues that are associated with it. And sometimes sleep not maybe on the top of your list that you want to talk when you meet for your provider for 20 or 30 minutes follow-up. I think that the key to address sleep problems is to get into the main core of a sleep issue and try to address that main reason that drives sleep problems in individual patient. And finally, we all need to use benefits of proper meal timing, adequate exposure to bright light, and enough exercise, which certainly will advance our ability to sleep well and to be alert during the daytime. So I spoke very fast. I realized that, and I could talk about this for 2 days, but I wanted to leave some time for questions and answers. And again, I'm really grateful to be with all of you today. And let's see if we have any questions. Thank you.
Great, thank you very much. Yeah, it was really a pleasure to have you talk today because I know there's nobody better than you to talk about sleep and Parkinson's. So appreciate it, as well as the studies that you're doing to help us learn more. And not surprisingly, there are quite a few questions. We probably won't get to them all, but we can get to a few here. One question here is, are there any specific diagnostic tests that can quantify the risk of developing Parkinson's disease among younger patients with a family history of Parkinson's disease who have emerging sleep behaviors in the absence of other prodromal symptoms?
I think that these example, for example, of this patient, right? If somebody has a genetic risks and if there is REM sleep behavior disorder, etc., I think that the best possible path is to join one of those longitudinal biomarker discovery studies that can help us understand the progression of this disease. Certainly, this is in the research realm, right? If there are concerns about this combination of factors that I mentioned, one can always reach to a sleep specialist if there is a specific sleep disorder that may be of concern, do neurological examination, etc. We are happy to provide those as well, but we really do not have a good established clinical battery that one can say someone who is 30 or 40 years old, do this battery of tests, and this quantifies your chance of developing the disease down the road. That's why we are doing these longitudinal research cohort studies.
Great, thank you. Another question, how do you determine whether your fatigue during the day is due to Parkinson's or to sleep apnea?
That's a great question. Well, if there is a coexistent sleep apnea, the first approach here would be to take a download and take a look at the deep dive of compliance and effectiveness of that intervention. If sleep apnea is not adequately treated, then that needs to be modified. Sometimes patients who have greatly treated sleep apnea may have residual excessive daytime sleepiness. In that case, we would recommend some pharmacological therapies that are approved in patients who have both effectively treated sleep apnea and residual excessive daytime sleepiness. If these two are kind of addressed and ruled out, then it is possible that sleepiness may be related to other elements other than Parkinson's disease, other than sleep apnea. But important factor number 4 here that I want to mention, that fatigue and sleepiness are two different concepts and very frequently confused. I would just say, if you believe that you are really having excessive daytime sleepiness and want to go and want to take a nap, but you simply cannot fall asleep, you still have that dreaded feeling of not feeling right, the chances that you have fatigue is much higher than you have sleepiness. So sleepiness and fatigue are different entities. I just wanted, this is a good opportunity to bring that, to emphasize this as well.
Thanks. And actually, I just want to take a moment to point out, because I see Hannah put in the chat that we're actually one of the clinical sites for your light therapy study. And she put a link in the chat where you can go to see the studies going on at our center, including this one, if you're interested.
Yes, David, your team has been really very helpful and did a great job in being one of the sites. So we really enjoy working with your group on the trial. So
thank you. And thanks to Lon Lowe at our site, who's
absolutely.